As therapists, we have to deal with shame in our patients at every turn. And sometimes shame is plain to see, but sometimes, in fact, oftentimes, shame is buried, even unknown to the patient, him or herself. And we've got to help them overcome the barriers to knowing their shame, because shame is so deeply hidden and oftentimes dissociated that it's very hard to get patients in touch with their shame. Removing what blocks the shame and helping them to express and come face to face with it in the safety of the therapeutic relationship is what's important. And as Patricia DeYoung, who in her book writes, she says, shame needs to be given light and air. And I think that that's a beautiful metaphor. We know that, shame is described as a sense of smallness, worthlessness, helplessness, and powerless in any given situation. And there's that, it's compounded by that feeling of being exposed, because feeling exposed, the thoughts are about what's the other person thinking about me? How are these people seeing me? So it's a concern about others' evaluation of oneself. How I see myself in the eyes of the other is the focal point. And you'd see that in very young children with their parents. They look into the face of the caregiver to see the expression on the face of that caregiver, and then they react. So when they see exuberance and joy, they are gleeful. And when they see a rather still face, they are disappointed. Now, that disappointment in the young child is the germs of early shame. And in fact, shame occurs at the age of 2 to 3 years of age. And by 4, shame is fully experienced when the child developed what's referred to as theory of mind. So rarely can people actually say, I feel ashamed or I'm embarrassed, unless, of course, when there's a better sense of self and somebody says or does something that they can actually acknowledge it. But otherwise, with the general types of patients that we see, it's rarely ever conveyed verbally. So shame is actually an entire organismic state. It involves the whole body. It affects multiple systems in the body. And in severe shame, the autonomic nervous system is triggered. But in chronic shame, even though this happens, shame is not easily visible. So let's look at how we can identify shame. Now, I must actually stress that it's not like, shame drops there in front of you, or a word is said that indicates shame, or an expression on the face like serious embarrassment, or the downcast face, or the averted gaze, or the non-eye contact. Now, these are not the ways in which we identify shame. If they happen, well and good. We know that shame's at play. But probably 99% of the time, we don't see any of these. Because as we're working with patients, various scenarios, various things that they say, various memories that they bring up in the therapy, various interactions and relationships, that's where we've got to listen and listen carefully. So behaviors can be inwardly directed or outwardly directed. So as I said earlier on, it's not seen on the face of those experiences. It's not going to be verbalized easily, unlike guilt. Now, guilt is one of those affects that's experienced when we know we've done something wrong, when we've wronged someone. But shame is unlike that. So we must also become familiar with ways in which shame is avoided. Because if we don't recognize shame, and I'm sure that all of you have been in that situation, shame becomes a barrier to treatment. And I think what it's one of those barriers to treatment, whether patients have been sexually assaulted, sexually abused, traumatized within families, by strangers, or they've experienced the trauma of war and displacement, or whether they've suffered the trauma of traumatic attachment, whatever may be the source of shame, if it's not brought to the patient's knowledge, if there's no knowing of shame, it continues to be a barrier preventing any forward movement in therapy. So let's say, for instance, in those few moments sometimes, if there's occasional slight embarrassment seen, or if there's slight aversion of gaze, or a lapse into silence. Now, a lapse into silence is not always a disjunction, I must remind you, because I think often we think that a lapse into silence is a disjunction. A lapse into silence may be a moment of shame. And so we need to identify it and empathically bring it to the patient's attention. Shame, like trauma, is timeless. So deal with it in the here and now. And it's only when you are doing further processing of shame and trying to find how has shame come about to be such a huge kind of like a roadblock. It's then that you actually then talk about the past, communicate the difference between then and now, but always work in the present. It blocks anything good in the self, and therefore you respond with understanding. Sometimes it's hard to have some compassion for yourself, might be a statement I'd make. Be prepared for it, for your empathy and your statements to be dismissed many times, but don't attempt to convince them about the good within them. It'll only increase negative feelings. Look out for non-verbal indicators of shame and be prepared to repair. So in healing shame, I don't matter in a safe relationship can be responded with, yes, that's how it is inside for you. It hurts the way you feel like you don't matter. Even though this slightly conveys a feeling that they matter to you, try not to insist, you matter to me, you matter to me, you really do matter to me, or something like that, because that conveys the opposite. So your empathic response conveys understanding and a willingness to stay. The story will unfold and a time will come when you can say, yes, you do matter. We will be invalidating them if we reassure and try to immediately make their shame better.